to metabolic disorders. We'll be discussing diabetes mellitus. There are two categories, type 1 and type 2. We'll discuss type 1 now. Insulin-dependent diabetes mellitus, IDDM. It's usually early onset, under 30 years of age. It requires insulin injection, diet therapy and regular exercise, and usually self-testing of blood glucose levels. Diabetes is a widespread and chronic disorder, and the body doesn't process food properly. Diabetes is caused by insulin insufficiency, and type 1 generally is where the body is unable to produce insulin, or too small amount that's needed to metabolize carbohydrate. So type 2, non-insulin dependent diabetes mellitus, NIDDM, that's usually late onset, although there is an increase in younger people. We hear a lot about childhood obesity nowadays. It's usually associated with an increase in body fat, abdominal fat, right around your spare tire. Reduced glucose tolerance and reduced insulin sensitivity. So type 2, its insulin may be excessive and body is not responding appropriately. Usually does not require insulin injections. For both types of diabetes, following a meal plan carefully will control the condition. Research has shown that the age-related rise in body fat is not as a result of greater food intake, but more of a consequence of less vigorous training. I want you to pause again. I have another task for you. Here is your task. Name 3 risk factors associated with exercise for someone with diabetes, or diabetes and the older adult. Okay, how did you do? The answers are coronary heart disease and coronary artery disease, being overweight, over fat, age, sedentary lifestyle, family history, smoking. They all have an effect on the disease. It dramatically accelerates it and complications that accompany diabetes. Hypoglycemia is the greatest risk after high intensity or long duration exercise. So let's look at the risk factors. Increased risk of coronary heart disease, as I've just said. Rise in total body fat. Hypoglycemia. Increase in total cholesterol. Family history, genetics. Decrease in immune and pulmonary function. Increased risk of infection due to damage to the small blood vessels and nerves. Kidney damage, blindness and amputation. And smoking is a risk factor, as I've said. I'd like to explain total cholesterol. The total cholesterol in older people rises. That is, the rise in triglycerides, a rise in bad cholesterol, which the LDLs, and a lowering of the good cholesterol. So diabetes is a real risk factor for heart disease. So, physical activity guidelines for diabetes. Number 1, ensure participant has diabetes controlled by food or medication. So that needs careful screening. A knowledge of the symptoms and the treatment of diabetic emergencies. Have readily available absorbable carbohydrate. And knowledge of complications associated with diabetes. Example, as I said, coronary artery disease and the decreased peripheral circulation and sensation in the feet and toes particularly. And as an instructor, you do not rely on a participant to bring something sweet with them. Older people can forget and do forget. So if you know you have a diabetic in your class, how you have something sweet, an orange drink with you, or an actual glucose sweet, or a little sugar sachet. So the guidelines continue. There would be knowledge of the risks and benefits of exercise for diabetes mellitus, and extra care for the feet and legs, as we've said, and there's a necessity of reducing body fat, which helps normalize blood glucose levels, especially type 2 diabetes. and in all cases, regular exercise plays an important role in the treatment of diabetes, so they need to exercise. Warning signs then of hypoglycemia are the shaky, dizzy, lightheadedness, sweaty, pallor, hunger, blurred vision, headaches, heart pounding. These are only some of them, obviously. Nervous, excited, anxious, tired, and no energy. Metabolic disorders continued. We're going to look at osteoporosis and osteopenia now. This is a disease characterized by the exaggerated loss of bone and by poor bone quality. It is a metabolic bone disorder, and osteopenia is progressive bone loss and is a normal part of human aging. Poor bone quality leads to bone becoming increasingly fragile and susceptible to fracture. Most common sites are the thoracic vertebrae, the neck of the femur and wrist, and 90% of residents in long-stay facilities may have some degree of osteoporosis. Fractures occur and do occur from simple routines and everyday activities, example bending, lifting, coughing, and in one personal experience, shaking a participant's hand too vigorously. The symptoms of osteoporosis are kyphosis, which is commonly known as the dowager's hump, decreased height, pain in the weight-bearing bones, especially back and hips, fractures, and falling. Kyphosis. This occurs in the thoracic vertebrae. Women can experience 10 to 15 years accelerated bone loss following menopause, but men needn't get too complacent as bone loss occurs with them after 70 years of age, and this accounts for the decrease in height in both males and females. But as women live longer than men, they are more susceptible to the consequences of osteoporosis. Fractures and falling are a major concern to health services. It is the leading cause of morbidity and mortality in elderly people, and I will be dealing with falls in a bit more detail shortly. So the physical activity guidelines for osteoporosis: do weight-bearing exercise, do strength training exercises, isometric abdominal strengthening exercise, resistant training exercise, posture promoting exercise, balance and coordination exercise, toning exercises, low impact exercise. Exercise programs for older people with osteoporosis should include cardiorespiratory weight-bearing exercises, brisk walking, aerobic, resistance, strength training, isometric abs. All exercise should aim to improve strength, coordination, balance and flexibility. But a special emphasis on postural training exercises, example, back extensions, are more important. In fact, the only time hyperextension of the spine would be recommended would be to promote posture with this particular metabolic disorder. This could be done in a prone position or even sitting on a chair. Postural education should be included as a preventative measure, preparing people with osteopenia and osteoporosis to stand, sit and move more securely in their daily lives. So, physical activity guidelines for osteoporosis: the things to avoid are forward flexion of the spine, twisting or fast movements, ballistic or jarring movement, too many repetitions, maximum 8 reps. You can always go back, but don't overload that joint. Minimize the risk of falling. Contraindications for this population include any form of spinal flexion. These movements put excessive force on the spine and may lead to back fractures and pain. Also contraindicated is chest towards knees or twisting of the spine. In some cases, gentle turns may be performed, with the exception of head and neck. In most cases, people with osteoporosis have less efficient reflexes and loss of strength, so this may impair their balance and lead to a fall. Now get out your pens and papers again. We have another task. Question. Since traditional sit-ups and curl-ups, forward flexion, are not recommended for individuals with osteoporosis, what exercise would you give to improve abdominal strength? Now your answer is isometric abdominal strengthening exercises. Example, pulling the stomach muscles in and up while sitting or standing. Back extension exercises for posture. And of course, don't hold your breath while performing these exercises. Did you get that? Remember, isometric exercises may be performed provided the participant doesn't hold their breath while holding in their abdominal muscles, and you often see that. Postural exercises may also be performed while seated. So let's look at falls. Falling and the impact of falling is a serious concern for older adults. While muscular weakness is one of the primary risk factors, other factors such as contractures, changes in posture, changes in vision and gait contribute. Contractures, what do we mean by that? We mean shrinkage or shortening of the muscle caused by disuse or extended periods in one position. Gait and balance, well, postural stability and normal gait mechanics are affected by aging, and this can lead to shorter and slower strides, not lifting the feet high enough, shuffling along. Increased postural sway, you often observed in women of a certain age, that kind of rolling sailor's walk is what they call it. All of these things contribute in one way or another to falling. So the risk factors associated with falls are they are unable to turn 360 degrees. Fallers have weak hip adduction, weak knee extensors and flexors, and weak ankles. They also can experience dizziness or vertigo, and medication which impairs balance. People as they age find it difficult to twist around to look behind them while they're walking. If someone called them, for instance, if a younger person called them, they would turn around and they'd walk to them in the same linear fashion, a straight line. They wouldn't twist around. They wouldn't look over their shoulder. So other risk factors include arthritis, impaired joint action, postural hypotension, which is actually too little muscle tone, and cognitive and functional impairment have a problem, kind of cause falling. That's sedating and psychotic medications. Vertigo is quite a common problem with older adults, but we'll be going into that a little bit more detail later. So the implications for fallers: loss of independence, cost of healthcare, cost of medication. Falling and fear of falling leads to isolation and depression, and even death. Statistics show that people who fall may not recover from the trauma of that fall, and while the fall itself doesn't kill them, the effects of a fracture and possible hospitalization can hasten their deaths. Older people become very fearful of venturing out in case they trip and fall, and this in turn leads to a loss of independence. Physical activity is so important. What I say is, it lifts the lid. L-I-D. It lifts loneliness, isolation, and depression. So, the guidelines for fall prevention. Effective fall prevention exercises are very important. Access to individual tailored exercise programs, very important. Ensure safe and correct movement patterns are performed. Proper advice on safety precautions for impairments and or joint replacements. Adaptation of exercise to minimise the risk of falling. Example, a wide base. No one leg stand without support. Now, when I said effective fall prevention, effective is the word here. We're all going to trip at some stage in our lives, but if we don't have the strength in our legs to stop ourselves falling, or once on the ground we can't get up, we will be in serious trouble. Older people have a particular dislike of the floor. They rarely get down there if they can avoid it. They're more comfortable at the level of the bed, say, or sitting or standing. So try and include strength exercises for the lower body, particularly while sitting. Example, hip adduction or abduction, flexion and extension of the knees, bending and straightening of the knees, any exercise that can safely take them off midline or centre of balance, like tossing or kicking a ball, obviously, safely. Another task coming up. Pause and take out your pens again and fill in the blanks. Okay, fill in the blanks as I said. Personalised blank and blank exercises are required to halt blank atrophy associated with ageing and to prevent blank. So I'm going to read it out again. How did you do? Personalised blank or personalised strength and balance, which was another blank, exercise are required to halt muscle atrophy. That was another blank. That is associated with ageing and to prevent falls. Okay, I'm going to read the whole thing. Personalised strength and balance exercises are required to halt muscle atrophy associated with ageing and to prevent falls. Remember, activities common to older people such as walking and gardening are not associated with gains in muscle strength, and this will possibly be a new concept for older people. So, do strengthening exercises, I've just said. Do stretching exercises, balance and coordination exercises, and specific exercises for ankle, knees and hip. And use special equipment specifically designed to improve gait and balance, right? So that could be a balance cushion or a wobble board or something like that. Random movements are great as well. Walking forwards, walking backwards on your toes, your heels, sideways, diagonally, zigzag, bending and straightening the knees. Any movement that takes a person out of that linear walking style. Toe taps, toe pointing, flexing. But of course ensure safety by clearing all obstacles from the exercise areas and provide adequate support for transitional movements or if they're using equipment.